Good afternoon, everyone. This is Doreen Cordova. I'm the Director of Telehealth Programs for MobileHelp Healthcare's Division. On behalf of MobileHelp, I would like to welcome you to today's webinar, Understanding CMS Reimbursement Opportunities for Remote Patient Monitoring. All attendees have joined in listen-only mode. However, you can submit questions in writing throughout the webinar in the app. We will try to answer all of those questions during our Q&A period at the end of the presentation. I would like to inform you that our webinar today is being recorded, including a written record of the questions you submit. So let's get started. Our two other speakers today, actually three, will include Michael Gomez, CEO, and Gary Carneal, founder and strategic advisor for Clear Health Quality Institute, and Chris Otto, Senior Vice President of the MobileHelp Healthcare Division. We are also joined today by Paul Reisner, General Counsel for MobileHelp, who will be available during the Q&A to answer any questions you may have. One disclaimer, while we will be talking about various laws and regulations, our experience and advice should not be taken as legal advice. If you have specific legal questions regarding your program or participation, please consult your attorney. I will now hand over the presentation to Michael Gomez and Gary Carneal to get us started. Thank you.
Thank you. My name is Mike Gomez, and I'm the CEO of Clear Health Quality Institute. CHQI was formed a little over 2 years ago and has quickly grown to become the nation's largest accrediting body of telemedicine and telehealth programs. Our seal of accreditation provides consumers, providers, payers, and regulators with an easy-to-identify confirmation of quality from an independent third-party organization, a patient and consumer benefit that had previously been unavailable for telehealth care in the past. Our goal is to promote access to safe, quality, and confident healthcare regardless of the telemedicine model or modality being deployed or the type of clinical services being provided to patients. We continue to refine our standards and expand our program offerings to include additional forms of telemedicine delivery and modalities. I want to congratulate the team at MobileHelp, who has partnered with CHQI as an early adopter of our upcoming Remote Patient Monitoring Accreditation program. Their efforts to seek accreditation for our newest program is a clear testament to their commitment to their customers and the quality of their products and services. Now I'd like to introduce to you Gary Carneal, the founder of CHQI, who will take you through a brief history of telehealth and the value of accreditation while discussing the future outlook of RPM. Gary?
Thanks, Mike, and thanks to MobileHelp. You know, when you think about healthcare and all the innovation, and when you have something like remote patient monitoring that's coming on, gaining steam, and talking about reimbursement, it's really interesting to see how accreditation can play an important role in terms of, as I'll explain in a moment, providing contingencies where reimbursement can come through. So we're all kind of familiar with the history of telemedicine. Obviously, it probably started around the late 1800s, early 1900s, when the telephone took off. And in fact, the first kind of modern telemedicine began in the early 1900s in the Netherlands when there was a transmission of heart rhythms over the telephone. And then kind of rotating into the 1940s, radiology began to take off, where there were radiology images sent in Pennsylvania over 24 miles between two townships via telephone line in the first world's example of electronic medical record transfer. And then you move forward to like 1959, where there was a video communication for medical purposes in the University of Nebraska, where there was a two-way television set up to transmit information to medical students across the campus. And then as you headed into the 1960s and 70s, you had NASA and the federal government begin to really develop remote patient monitoring applications, such as Alan Shepard when he flew in Space Freedom 7. He was obviously the first American in space in 1961, and they actually monitored him through a primitive EKG and a respiration sensor and a microphone and a thermometer. And then later, through the Mercury flights, a blood pressure monitoring device was used by the astronauts, among some other remote patient monitoring standards. And so if you look at also from the lens of accreditation, sometimes it takes a while as we figure out what virtual care is to kind of create a framework. And so In my work, I've brought 25 different accreditation programs to market, and these are some of them on the screen right here, starting back in the late 1990s for nurse triage standards, health call center standards, and case management, and I'll talk a little bit about our work today through CHQI. Next slide. When you think about accreditation, there's really a lot of benefits to accreditation, a lot of reasons to do it. Obviously, at the end of the day, it's about reimbursement. And so accreditation can promote quality-based standardization and outcomes-driven healthcare. It can identify and mitigate risks to both patients and organizations, and empowers the use of evidence-based clinical pathways to promote better clinical outcomes. They can document, maintain, and update their workflows, and encourage streamlined healthcare services. And it really does set the stage for reimbursement in terms of having people understand kind of what the service is doing, in this case, remote patient monitoring, and also, for example, filling in regulatory gaps and creating a national standard. Next slide, please. So as Mike mentioned, ClearHealth Quality Institute was formed several years ago. I think the important point here is that we've taken all the bells and whistles of the best-in-class accreditation function. We're leveraging my 25 years of accreditation experience in the ATA's 25 years of clinical experience as a trade association. So we really have a good foundation to build our programs. Next slide. So part of this is actually building a typology. So as you can see in this slide, the core telemedicine accreditation standards that were adopted, taking the ATA's initial program last year, we have three basic buckets. Consumer to provider, which would include, for example, physician or nurse triage interaction, where the consumer calls the physician. Provider to consumer, which would be like an ongoing therapeutic relationship between a mental health professional and a patient. And provider to provider as a third bucket, which would be, for example, teleradiology, especially consult. And within each bucket, there are different service lines. This took a huge step forward in terms of creating that typology that would get both public and private payers excited about potentially reimbursing for the remote patient monitoring. Next slide. But to carry the ball forward, it's important that in terms of today's environment of value-based purchasing, that you kind of make sure you demonstrate outcomes. So part of our work today is we're developing a fourth module that'll right on top of the existing three modules that actually activate the National Quality Forum outcomes framework that was adopted in August 2017. We're taking their four domains and adding a fifth. So basically, this is a soup to nuts outcomes program demonstrating for each service line certain measurements related to access to care, clinical effectiveness, experience, patient satisfaction, financial impact, and operations measurements. And next slide. And then finally, we're beginning work now, and actually Chris Otto, who's speaking today, is actually on the remote patient standard work group. So we're actually now in the process of drafting standards. As you see to the left of the slide and up to the top of the right side, you see the core standards are actually part of the telemedicine accreditation program. So we're kind of leveraging that kind of core infrastructure. We're going to modify the standards, and then you can see on the bottom right kind of the remote patient module. So it really gets to the point of, what are the program goals? What's the provider and personnel service line capacity? What are the clinical procedures? What's the end user technology proficiency? What's the provider-patient relationship? What's the continuity of care? What's the patient population served, and so on. So it's that kind of process and structure assessment that really kind of creates a framework for reimbursement. And with the recent CMS codes, including CPT code 99457, it's going to become even more important, and you'll hear more about those codes in terms of potentially leveraging accreditation to, for example, there's over 20 state Medicaid departments now that reimburse at some level for RPM. So we look forward to participating in the call today and answering any questions, but accreditation typically is the first step forward in terms of really people understanding what remote patient monitoring is. We're hoping to have these specific standards, which will be a separate accreditation program, completed by August. We'll do a public comment in the fall and hopefully have it all wrapped up by the end of the year. So I'll stop there and look forward to the rest of the webinar.
Okay, great. Thank you, Gary. I think it's really exciting, and I appreciate the overview of the evolution of remote patient monitoring. And I think the establishment of standards is really a testament to the maturity of the space, as well as the reimbursement that's now offered by CMS. So just as a refresher, or maybe for those of you that may not be familiar with remote patient monitoring, really what we're talking about is technology in a patient home. This may include connected self-test medical devices like a blood pressure monitor or a weight scale or some hub in the home for communication that allows patients that have a chronic condition to collect data and then transmit that to their clinical team that's monitoring that data. So clinicians typically can use a software platform that allows them to collect health and adherence data on those populations, and then to receive notifications of abnormal readings and non-compliance that allows them to prioritize interventions for patients in that population. Next slide, please. All right, so today we'll be talking about the reimbursement that's now available through CMS. There's 3 codes that we'll be talking about, and I'll point out that this is really, we're talking about today the codes as they are defined for Medicare Part B. So today this is available for Medicare Part B, and the way it's defined is remote monitoring of physiological parameters. So I think it's interesting to note here that those of us in the industry will often we will often refer to RPM as remote patient monitoring, but CMS is very specific in their language to denote remote physiological parameter monitoring, and the emphasis is on collecting data associated with some sort of vital sign. They've provided examples in the language of the code that refers to weight, blood pressure, pulse oximetry, respiratory flow rate, blood glucose readings, but these are not intended to be an exhaustive list of examples. It's really up to the physician or the healthcare provider to determine what's medically necessary. Next slide, please. So I'm not going to go into detail. We have a couple slides where we'll go into detail. So just know that these codes that we'll be covering today, the 3 CPT codes, are all effective January 1st, 2019. These are not face-to-face codes, so they are approved for remote care, and I'll refer to them interchangeably as RPM, as either remote patient monitoring or remote physiological monitoring is the language that CMS uses. Again, this is for Medicare Part B. CPT 99453 is a one-time code. You can go ahead and advance the slide, Brenda. Yes, so CPT 99453 is the first code. This is a one-time code. It means it can be billed once for the duration of care for that patient on the RPM program. It is really designed for the initial setup and patient education use of the equipment. So I've had a lot of partners ask us if that education needs to be delivered in person or can it be over the phone. The answer is yes, it can be delivered over the phone. I will point out that for all of these codes, whichever ones, you don't necessarily need to bill for all of these codes, but for any of these codes, consent is required by the patient. So they have to opt into the program. They have to have been seen at least once in the past year in office, and then they have to opt into the program. That consent can be collected in person or over the phone, and this code is billed one time. The next slide, please. The next code is CPT 99454. This code is intended to cover the device supply with daily recordings and or programmed alerts transmission for the initial 30-day period and each 30-day period. So this code is intended to be a recurring, can be billed monthly, and it's essentially designed to cover the cost of the technology in that patient's home, as well as the software or whatever tools are being used to aggregate that data. So we'll talk about this in detail a little bit later, how the MobileHelp solution, works inside this code, but this is really for the technology. Next slide, please. And the next code, CPT 99457, is the code that's designed to cover the 20 minutes or more of clinical staff, physician, qualified healthcare professional time in a calendar month requiring interactive communication with the patient and caregiver during the month. So this code covers the review of the patient data. So again, for every patient that's in your practice that's participating in the remote patient monitoring program, there is a requirement by CMS that you must satisfy 20 minutes of review in that billing period. And we'll show you later that we do have software that demonstrates and automatically will record the time spent towards this requirement, but it is a requirement that you have to meet this. I would also mention that for 2019, at least under the current law, this CPT 99457 must be delivered under direct supervision of the billing practitioner in this case. So with respect to CMS, they have defined this as clinical staff, physician, or other qualified healthcare professional time, but they were not specific in the supervision level, and the default supervision level for CMS is direct supervision. So unlike chronic care management codes, if there's some of you that are using those codes today, there was an exception in the language made so that it was approved for general supervision. But at least for today, with respect to CPT 99457, that 20 minutes has to be delivered by clinical staff or other qualified healthcare professional time under the same roof, under direct supervision as the physician. All right, so just to summarize, there are 3 codes. The first one is for the setup and patient education. We also talked about the consent that's required to be collected. That is not necessarily coupled directly to 99453. So if you choose not to bill for 99453, you still have to collect consent. But I think it's generally, we sort of associate that with the patient enrollment tasks, get the patient on program. That's a $21 reimbursement one time, to be billed one time at the onset of care. The next code, 99454, is to cover the technology and the delivery of the physiological data. That code varies by locale, anywhere from $55 to $74. So please consult your physician fee schedule for the actual reimbursement rate in your area. I've seen a lot of blogs and articles refer to this code as $65 or $69 nominally, which is kind of the average, but it does vary by locale. So please be aware of that. And then the last code is the 99457, which covers the clinical oversight, the review of the physiological data as captured by the RPM equipment. And that varies anywhere from 47 to 56, again, varies by locale. So on a monthly basis, you have a little bit of a additional reimbursement on the first month, but then on an ongoing basis, that reimbursement ranges between $102 to $130, depending on the locale. Of course, this is subject to the 20% copay for Medicare Part B. Next slide, please. So I know everybody's eyes are probably going to go to the numbers first, but if you would just look at the bottom of the slide, and I want to point out that, and as Gary alluded to, remote patient monitoring has been around for a very long time. In the last couple of decades, it's been widely used and has shown very effective, especially with heart failure patients, to demonstrate a reduction in readmission, anywhere from 50 to 60% reduction in readmissions for patients that have congestive heart failure by using a simple connected weight scale that can monitor their weight. In addition, it's shown to be able to improve patient engagement. We've received feedback from a lot of practices too that they've been able to improve access to care for those patients that can't come into an office or it's not practical to come in. They've been able to better manage chronic conditions, promote skill development for self-management of diseases, and also to be able to allocate precious in-clinic time for those patients with higher acuity that need that time in the clinic. So there's a lot of benefits. What's new for 2019 is the reimbursement. So now, while the outcomes and the benefits have been pretty well documented, we're really excited that CMS has really embraced the value of remote patient monitoring, and they're now making that available in a big way so that providers can deploy this and get reimbursement to do so. So the numbers you see on the screen are just an example. It would vary by practice, but we assumed a 2,500 patient population. We assumed that 32% of them were eligible for the program and were on Medicare Part B. So this will obviously vary widely by practice. And then we assumed that 30% of that practice would participate. So these are, I think, pretty conservative numbers. So you can see here, month 1 through 12, we show 20 patients onboarded per month, or 20 patients enrolled in the program per month, with a total of 240 patients on program by the end of the year. And you can see some of the numbers just in terms of what the reimbursement actually provides on a monthly basis and how that adds up over time. Again, I'll point out that this is assuming that 100% collection of copays. We know, of course, that you are required by law to bill for that copay, but we're just pointing that out as a caveat because I know in practice it's not always as easy to collect 100% of copays. So it will, again, that'll vary by practice. So we just highlighted that here so you can be aware of that. Later in the webinar, we'll talk about the actual prices. I will just say that the MobileHelp RPM solution is designed to be a per patient per month model. There's no upfront expenses, and it's designed to fit inside the unit economics of 99454, the technology reimbursement. So you can see how this revenue accumulates over time, over that 12-month period. $30,000 in fees, in reimbursement for this example population. The red line that you see on the screen is what is the reimbursement without the copay. So, depending on what your own history and success is on collecting copays for patients, we would expect that would probably be a similar collection rate. So just be cognizant of that as you're building your program, and we drew the red line on here to denote the where the copays were. Okay. The how-tos, implementing a successful telehealth program. We do have some resources on our website, and we are very collaborative with providers that we work with. So everything that we do is very collaborative. We have program plans in place to define remote patient monitoring, and we will customize those and tailor those during a typical onboarding phase for practice, and we'll talk a little bit more about that. We do have some white papers on our website as well, so feel free to visit our website, and these are freely available to you. We cover some of the considerations to putting a successful remote patient monitoring or telehealth program in place, personnel considerations, identifying the inclusion criteria, what populations you want to focus on, and defining what outcomes you're seeking to achieve. I will point out that this white paper in particular was originally written with a focus on home health. I did see a number of home health agencies that enrolled in today's webinar, so you especially may want to visit our website and access this resource, but I think it's a good resource for anybody starting an RPM program. Okay, selecting the right partners. I'm actually going to hand over the stage to Jareen Cordova. Jareen, do you mind taking over right here?
Yeah, absolutely. I'm happy to talk about selecting a good vendor partner. There's a lot of considerations when you're selecting a vendor partner to support your remote patient monitoring program. And the first and foremost is that this is a long-term relationship. We walk through the process with you in terms of planning your program, implementation, launch, and what type of supportive features you need to have built in for the long haul. Post-implementation, we're looking at adoption for patients. So it does take a good partner to support your program. Next slide. First and foremost, you want to select a vendor partner who's easy to work with. It's one that will supply you with a simple contracting process and clear, transparent terms. Customizable programs, meaning you might have an idea for your RPM program today, but plan to make changes in the future because you may want to expand beyond your initial populations. You might start out with congestive heart failure, COPD, hypertension, diabetes, and down the road, you may include other populations or change direction. You want a partner that can be flexible and meet your needs when you have change. Also, responsiveness. It's about communication between yourself and your vendor partner. You want to make sure that you have multiple checkpoints to determine whether or not the program is successfully on track, or if at any point you need to create a change to address something that occurs along the way. So definitely communication and responsiveness are important. Next slide. Pricing. Pricing is an interesting discussion because you really have to be thoughtful about what is included in your upfront pricing. Inclusive pricing, especially if it's a bundled rate, a per patient per month lease model, it allows you to be aware of what's included in that pricing. If the software is included, the hardware, shipping to the patient, definitely you want to know all the details up front and not be surprised by any cost of add-ons later on. So be aware of your pricing model. Next slide. In terms of the overall program management, you want a vendor partner who can support you in either a branded program that might require some marketing tools. Patient onboarding may require foundational tools such as intake forms, consent forms, disenrollment forms, and you want to make sure that that enrollment process is easy and you can expedite quickly. If you've identified a patient to participate in your program, you want to know that within a few days that patient will have their kit in their hand and be ready to start taking readings. Pre-configured kits are also helpful. If the kits are already paired before they leave a warehouse, shipped directly to the patients, and if they're plug and play, then patients are able to launch into their program quickly. Also, support. Support is critical to the success of your program. If there's any point at which there's a challenge with data flow, connectivity, or devices, you want to be able to pinpoint exactly where the system's breaking down, and you want your clinicians and your patients to have access to a support team that cares and is able to walk them through the process of identifying problems and fixing those problems. Next slide. So in summary, with an RPM program, really what you're trying to do is improve your quality of care. It's an enhancement to your current model of care. We want to give you a program that will strengthen your clinician-patient relationships, improve your retention. You want tools that will help you better manage your patients with chronic conditions. To date, you've all been doing activities that are between clinical visits to help those patients with chronic conditions. Now you can get paid for that. So in short, we really want to provide a program that helps to lower the healthcare costs, improve efficiencies, and improve quality overall. So with Medicare reimbursements, it's really easier than ever. Next slide. So in short, why work with MobileHelp? Well, we're easy to work with. We've removed all the barriers to adopting and launching a program. We've made it simple for your team to be able to provide remote patient monitoring to their patient populations without a lot of hiccups. We offer clear and friendly terms, meaning we do not require a capital investment. You do not have to purchase hardware and devices to inventory on your own. We provide a per patient per month lease pricing, and we ship freely to the patient. So there's no cost in shipping directly to the patient. And again, it's plug and play technology. We also offer step down private pay options, meaning at the end of your patient's program, they're able to access a private pay program and you can support durability of benefits. So all the logistics are included and the technical support. And I see that we are toward the end of our time. We do have a few questions. So in short, if you select a kit option, you can select from 2 different hubs, a simplistic hub, an engaging tablet hub, and a variety of peripherals for any program needs. Next slide. If you have any questions, you have contact information for any of the participants on today's panel. And I would like to hand over a couple of questions Gary, I'm going to shoot a question your direction first. Is accreditation required to participate in RPM reimbursement?
Yeah, that's a great question. It's interesting when you look at an application like MobileHelp. It's embedded in terms of clinical pathways, and then there are other types of remote patient monitoring devices like Fitbit, which really doesn't qualify. So what purchasers are looking for is really some sort of sign and signal that it's a company that's really well structured, that they know what they're doing. So currently, accreditation is recommended for RPM reimbursement, but technically it's not mandated at this point. But to be aware, for example, one of the largest RFPs in the country right now, issued by Evaluate, the National Alliance for Healthcare Purchasers, Evaluate actually does ask for telemedicine accreditation, whether they're accredited, and they will be asking for remote patient monitoring. But for example, in some cases, CMS actually will mandate accreditation. You actually need an act of Congress typically, or some regulatory guidance. But for example, for advanced diagnostic imaging, if you're an imaging provider and you want to get paid for Medicare beneficiary, you actually do need an accreditation pursuant to the MIPA program. So today it's recommended but not mandatory, but it could be mandatory in the future.
Great, thank you. This one is directed at Chris Otto. Is this reimbursement available to home health agencies?
Unfortunately, the CMS codes that we're describing today are intended for a billing practitioner providing for the physician providing care for that patient. So next year for 2020, there's been a lot of discussion about reimbursement for home health, and certainly PDGM has been a big hot topic for home health agencies. And I know there are some home health agencies that are planning to deploy RPM under PDGM as sort of an operational cost savings to deliver better care. But unfortunately, no, these do not apply directly to home health.
Great, thank you. Chris, another one directed towards you. What are the big challenges that people are facing with regards to starting an RPM program?
Oh, well, that's a good question. I think the physicians, the practices that we worked with that have struggled the most are those that have attempted to provide their own technology and sort of deliver a bring your own device, meaning bring a smartphone or your own tablet and you're collecting the data yourself. And I think this has been a nightmare. It works on small scale, 10 to 20 patients, but if you try to go beyond that, certainly 100 patients or more, it can become a logistical nightmare. You're out of the business of providing medical care. Now you're providing technical support. So Jareen, you actually alluded to this when you talked about selecting a good vendor partner, is identifying a partner that can do all this for you. So we take pride in some of the logistics management and the pre-pairing of kits. I mean, we really make things simple so that the practices we work with can focus on delivering quality medical care and not supporting the RPM technology concerns.
Great, thank you. Another question, and I will direct this towards Chris first, and then Chris, you may want to share this one. There were several questions that came in, and they were phrased in different ways, but pertaining to consent. Exactly what are the requirements for obtaining consent, and how do organizations need to maintain a record of consent?
Yeah, good question. The first is that first I'll just say I'm not an attorney, but so maybe Paul, you can jump in here. But the consent does not have to be collected in person, so I think that much is clear. It can be collected over the phone. I believe it has to be documented in some way. Paul, correct me if I'm wrong, but I think memorialized is the language I've heard you use to just to document that and memorialize that in the EMR some way.
Yes, Chris, this is Paul, and I would agree with that the consent just has to be in the record somehow. And if it's contemporaneously memorialized, the patient tells the recorder, whoever's taking the information, and it goes into the record. That's how most of the electronic medical records are set up now. And there's not a voice recording of the consent. So I think that would be sufficient.
Thank you.
Great, thank you. Another question is around the adoption of RPM since the release of the codes. Chris, can you expand a little bit on the experience that MobileHelp has had in the marketplace recently since the introduction of the 2019 CMS codes?
Yeah, it's definitely created a driver for the market. I mean, this has been big. So I was at the ATA conference in New Orleans maybe a month ago, and the session that was on this topic specifically, RPM reimbursement, was standing room only. There was, and most of the audience in the room were providers looking to deploy this, and we're actively deploying a number of programs as we speak. So I expect that the market adoption will be very similar to chronic care when it was rolled out in 2015, and we expect RPM will kind of follow a similar adoption.
Great, thank you. Who specifically can bill for CPT code 99457? And Chris, I think you can tackle that one.
Yeah, I'll take a stab at that. It has to be a physician. It has to be a billing practitioner. So this is somebody that's and again, because direct supervision is the requirement today, 99457, you have to be providing that 20 minutes of review, under the same roof, so to speak, is the direct supervision requirement. But it does not necessarily have to be primary care physician. It can be, it can be an internist or a specialty group. But I think the spirit of the law is that code is intended to provide the reimbursement for any practitioner, any physician that's providing that care for the chronic condition. So, if it's a diabetic patient, it may not necessarily, maybe a specialist that's providing that care on an ongoing basis.
Are mid-levels or maybe nurse practitioners, PAs, are they also considered billable?
Oh, that's a good question. I may defer to Paul to help me on this one, but I do. Yes, that varies by state. But if you are a billing practitioner, so if in your state the nurse practitioner can bill Medicare, I believe that is possible. Paul, can you validate that?
Yeah, I can confirm that. Yeah, if they're able to bill for other procedures, then this is one they would be able to bill for as well. Otherwise, the billing number is assigned to a physician or another healthcare practitioner who has the ability to bill, and it has to be billed under that number, and they have to bill it.
Great, thank you. And then one last question we have time for. With regard to building an RPM program and pulling together the hardware kit, is a BYOD program an option?
I'll be happy to take that one. And I sort of alluded to that on the challenges question. It is, first of all, it is an option. I mean, it would qualify with respect to the CMS codes that we're discussing, but I would strongly caution against it. And the reason is for the reasons I mentioned before, there are a myriad of devices out there, smartphone devices, different operating systems, Android devices, different iPhone devices, and trying to manage that in a heterogeneous patient population and trying to support that is a daunting task. So I would really caution against that. I would recommend that you find a good technology vendor, an RPM vendor, such as MobileHelp or some other for that matter, and rely on your partner to manage the technology. So I guess the answer is yes, but I would caution against it.
Yeah, and I think I'd piggyback on that I like the idea of a standardized program and one that you can manage the technology and the support, and it's cohesive program in terms of outcomes too. So I think that I feel the same way. And I think that's all we have time for today. And I want to thank everyone for joining us and for your questions. We'll follow up with any additional questions that we're not able to get to on this call. And we'll send an email with a link of today's recorded webinar. So be on the lookout for that. And thank you. This concludes our webinar for today. Have a great rest of your day.